We're going to talk about glaucoma secondary to inflammation. And just a note that glaucomatous-cyclitic crisis, or Posner-Schlossman syndrome, and Fuchs heterochromic iridocyclitis are covered in their own modules, so I'm not going to talk about them here. In most eyes that are inflamed, the intraocular pressure decreases. And this is due to a breakdown of the blood aqueous barrier that's part of the mechanism that allows aqueous production. But in some eyes, the outflow is compromised more than the production. And even if the intraocular pressure is normal early on or even low early on, it can go up later as aqueous production returns towards normal as the inflammation abates. And the corticosteroids that we use to treat inflammation can themselves elevate intraocular pressure, particularly over an extended period of time. So the message here is you really need to remain vigilant in these patients. You can never really let down your guard. Any inflammatory process can lead to elevated intraocular pressure. But the keratouveitis that we see in herpes simplex and also herpes zoster is especially prone to elevate the intraocular pressure. The mechanisms by which inflammation can cause elevated pressure are both open angle and closed angle mechanisms. Open angle, one can have direct swelling of the trabecular meshwork or trabeculitis, and this is an angle of a patient who has actual inflammatory deposits over the trabecular meshwork. The meshwork can become clogged with debris, and aqueous protein alone can diminish aqueous outflow. And in chronic inflammation, a membrane can grow over the trabecular meshwork, somewhat like neovascularization, and cut down aqueous outflow. And lastly, the special case of scleritis, there can be an elevated episcleral venous pressure that prevents aqueous outflow. And of course, corticosteroids, and we'll keep coming back to that because the steroids and the inflammation really make this hard sometimes to puzzle out. Closed angle mechanisms, one can have peripheral anterior synechia that form in areas where there's an accumulation of inflammatory debris in the angle and permanently close the angle. This is a patient with VKH who has inflammatory glaucoma. This Lee Allen painting just shows the fact that if you have a synechia or areas of synechia, there's often a line of pigment anterior to the synechia. One can also develop central posterior synechia that can cause pupillary block and angle closure, as you can see in this eye here. This is a great picture that shows broken synechia on the lens capsule up in here, but really shows nicely this pupillary block because the iris is now stuck down on the lens. Sometimes you'll see an eye like this where most of the iris is stuck down, but there are little areas where there's fluid still flowing through. And in the past, I would do an iridotomy on these patients. I think probably they're better left alone and allowing the aqueous to come through, rapidly pouring through this little area here. If one makes an iridotomy, that adds more inflammation. It decreases aqueous flow through this little defect and can cause this to close off, and then the iridotomies have a high chance of closing off. So one could do a peripheral iridotomy, or one could decide to leave this eye without an iridotomy. Sometimes posterior inflammation can cause swelling of the ciliary body with forward rotation. I think this is pretty unusual. And in chronic inflammation, very, very long-standing inflammation, there can be neovascularization and neovascular glaucoma. So there are a lot of mechanisms. Which of these would you do an iridotomy for? PAS, central posterior synechia, posterior inflammation with ciliary body swelling, or neovascularization. And the only one that's a pupillary block mechanism is one with posterior synechia. Treatment is to treat the underlying inflammation. As the inflammation subsides, the pressure might go down, but it could also go up. So again, one needs to stay vigilant. Aqueous suppressants, always the right answer, pretty much. There's a controversy about prostaglandins. I think early on we didn't use them much because of the concern that prostaglandins are part of the inflammatory cascade. But I think more and more, many of us are comfortable using prostaglandin analogs instead of doing surgery or other interventions. I don't believe it would be the first choice of medications to control glaucoma in an inflamed eye, but it's not absolutely contraindicated. Cholinergics, on the other hand, like pilocarpine, are contraindicated. They move the lens iris diaphragm forward, which is not good in terms of creating peripheral synechia, and the meiosis can encourage posterior synechia formation. Trabeculoplasty is not indicated in people who have inflammatory glaucoma. Trabeculectomy can sometimes fail because of the stickiness that's involved with inflammation, and tube shunts may be a better alternative. The quandary always comes of the patient who has a high pressure 2+ cell. They're on 4 times a day prednisolone. Do we increase or decrease the corticosteroids? You need to go one way or the other, and I think most of us would feel that it's better to increase the steroids and try to control the inflammation rather than backing off in an eye that's already inflamed. So the main points here are that inflamed eyes typically have low pressures, but elevated pressure can occur from both open angle and closed angle mechanisms. Closed angle glaucoma has both pupillary block and non-pupillary block mechanisms, and the corticosteroids make management challenging. So I think inflammatory glaucomas are very challenging for all of us. We never quite know which direction to proceed in. The use of the steroids really muddies the water in managing these patients.